Hello, this is Dr. Matthew Andrews. This presentation is Chronic Pain and Appropriate Opiate Prescribing. This is for the Michigan Podiatric Medical Association Great Lakes Conference, February of 2023. This is a pre-recorded lecture, so the material should be relevant and up to date. I've gone through quite a bit of material to kind of update this with the new CDC guidelines. And my contact information is at the end. If anybody has any questions, by all means, certainly feel free to email me directly. And I do believe I'll be participating in a live session following this presentation as well. So my disclaimers, I do have a few consulting agreements, but none that conflict with any material that is contained within this presentation. Myself, I wear a couple of different hats. Currently the residency program director at McLaren-McComb Hospital, which is the evolution of the Kern program. I'm in private practice. I have offices in both Oakland and Macomb counties. I do run a medical group here in Oakland County, and I'm a chronic pain enthusiast, more so giving than receiving. But this is something that I've been lecturing on for the past couple of years with pain management, and now that it's part of our required contact hours for continuing education, it's something that I've been kind of roped into and I try to stay on top of so as to provide relevant and up-to-date information. This material is a little bit on the drier side, so I apologize. It's not as exciting as some of these other lectures that are given at the MPMA. However, I try to make it at least a little bit interesting, and I try to break it up with some memes a little bit. So goals for this presentation, we're going to discuss a little bit about chronic pain syndromes and indications. This is fairly short. We'll talk about evidence-based prescribing of opiates, and then also kind of an update on the opiate crisis with some of the newer data that's coming out. We're starting to see kind of a downtrend in both use, but the death rate is still significantly high. That's something that we'll dive into a little bit. So we'll start with our classic definition of pain: unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So keep in mind that pain is an emotional experience just as much as it is a sensory one. And even the perception of pain or the thought of pain oftentimes can be enough to elicit a severe adverse response in people. A good example of this is that we will sometimes see patients that are absolutely terrified of pain, and that's a big red flag sometimes for opiate abuse disorder, that they have this just abject terror associated with any kind of pain stimulus. Acute and chronic pain are definitely not alike. Acute pain is very straightforward. This is post-surgical pain. This is I accidentally stuck my hand in a campfire type pain where you have a significant amount of tissue input, whereas chronic pain has an emotional component just as much as it does an actual physical stimulus. So good examples of chronic pain are something that we'll discuss as well when we talk about the dopamine reward system a little bit later in this lecture as well. So these are things that will play into chronicity of pain and oftentimes offer a very simple view of how patients have a difficult time being able to abstain or to get away from use of opiate medications. So chronic pain syndromes, which is more of what we're going to discuss this morning with regards to opiate use and abuse. I put the F word on top here, fibromyalgia. I'm kind of a categorical non-believer in fibromyalgia. I think this is kind of a garbage can diagnosis. And even though there are defined diagnostic criteria by the American Academy of Neurology for what fibromyalgia actually is, a lot of people that are diagnosed with fibromyalgia probably actually have something else going on, whether it's like polymyalgia rheumatica, and another oftentimes missed one is called MTHFR deficiency, which is a genetic deficiency, and it usually pops out in women from a symptom standpoint, usually in about the 4th, 5th, or 6th decades of life, even though it can affect men also. MTHFR is an enzyme pathway in folic acid synthesis called methyl tetrahydrofolate reductase. That will not be tested on. That's kind of a mouthful, but I think a lot of people that are actually diagnosed with fibromyalgia actually have more of a genetic component than they actually do an actual defined fibromyalgia. Non-articular rheumatism and regional pain syndromes. These are things like chronic inflammatory, things like osteoarthritis, osteoarthritis of the spine, especially when you have some impingement of the spinal nerve roots, regional pain syndromes as well. A lot of these are neurogenic in origin, as is CRPS. CRPS is notoriously very difficult to treat, and oftentimes tends to be a chronic condition through which we can be very, very aggressive about things like use of spinal stimulators and aggressive physical therapy modalities, but these are very, very difficult syndromes to treat, and oftentimes opiate therapy is maybe only 20 to 30% effective against it. And in some cases, realistically, your opiates may just kind of knock you out so you can sleep a little better, and that, as far as I'm concerned, is perfectly appropriate use of limited use of opiates in that instance. Ischemic pain, as we well know, ischemic pain is very, very difficult to keep on top of. Oftentimes the only thing that's actually going to help ischemic pain is going to be either restoration of blood flow or amputation of the involved body parts. In our world, that's lower extremity, of course. Spinal cord injury, again, neurogenic pain, multimodal pain, and then other, I kind of tossed in here, neurodegenerative and inflammatory processes. So these are things like multiple sclerosis, which can be associated with pain syndromes, ALS, chronic inflammatory demyelinating polyneuropathy, or CIDP, which is kind of a long form of Guillain-Barré syndrome. That's been associated with some vaccine injury type problems that have made headlines in the past couple of years. So these are all chronic pain syndromes that are largely multifactorial. They're not just solely a somatosensory pain experience. There's an emotional component to them. There is a neurogenic component to them. So these are chronic pain syndromes, and as we'll kind of discuss here with our clinical practice guidelines, that opiates are not necessarily always appropriate and or even indicated for a lot of these conditions. I told you I'd try to break it up with some memes here a little bit just to keep things flowing. So prescribing guidelines, these are prescribing guidelines as of 2022. In the state of Michigan, this was entered into law, I believe, in 2017, 2018, and then has now been recently being enforced, where you have to query the MAPS database for every controlled substance prescription that you write, unless it's in certain instances, like it's in a hospital or for acute pain, less than 3 days of a prescription's worth. So everybody has to have login or access to the PMP Aware, which is the Michigan Automated Prescription System. That is a database for providers and for pharmacies to determine patient opiate consumption and controlled substance use. It's not just for opiates, but it's also for other controlled substances such as Ambien, Lyrica, and other medications like that. Every prescription must have a MAPS query associated with it, or at least on the day of, and you must document in the chart that the MAPS was queried. So the easiest way to do that is to just enter in your chart documentation what their PMP Aware score is, because it flashes at you with that score. Your patient has a score of 290 or whatever, as far as their risk for problems associated with opiates. The highest one I've ever seen, by the way, I believe was 680 or so in a patient that was on like opiates around the clock plus short term as well, plus they were on some sort of like benzos as well, I think. So somebody was just kind of a mess. I don't know if anybody's seen anything higher than that, but I'd be certainly interested to know. You must document that a bona fide prescriber-patient relationship exists. So what does this mean? Does this mean that if my partner sees a patient, can I then prescribe them an opiate if my partner is out of town? Yes, that actually does count, because the patient is an established patient of the practice. But you have to just have documentation that a bona fide prescriber-patient relationship exists. You can't just write an opiate medication for anybody for any specific reason. They have to be either an established patient of your practice, or you have to have some sort of active treatment relationship with them. Patients must sign a consent form after discussion of risks and benefits, and the copy of the signed form must go in the chart. I've got a copy of what that form actually looks like. And guidelines for the state of Michigan: you may not prescribe more than 7 days of narcotics for acute pain, and that mirrors federal guidelines as well. So that gets into kind of the gray area about what's acute pain versus chronic pain. But for acute pain, we're generally talking about immediate release opiate medications such as Norco and Percocet, so hydrocodone and oxycodone in their short release forms. So here's the opiate start talking form. Most people have seen this by now. You can certainly automate this with your EHR. This is a very straightforward form. Basically, this is a patient acknowledgement that they're assuming responsibility for opiate use. And it's important to take some time to counsel your patients as well. just so that they have an understanding of what your expectations are for opiate prescribing. Let them know that these medications are controlled substances. They are drugs of abuse. They need to be protected. How often do we hear stories like, hey, my purse was stolen and it had my Norcos in it, things like that. Well, you know what? You have a defined number of pills for a defined timeline, and you can't get any more before that date. So setting those boundaries with patients will save you a lot of headaches, and it will also make sure that your expectations are known with the patients as well. So these rules do not apply for inpatient prescriptions or for ED prescriptions of less than 3 days. So take the time to actually counsel your patients, of course. Let them know what your expectations are. It will also help kind of weed things out for you. People can be very assertive if they know that they can get pain medication out of you. A good example is somebody, after they'll have an injury, whether it's a strain, a tendon rupture, a fracture, whatever it is. And they'll say to you, hey, my brother had some Norco left over from his shoulder surgery and I took one of those. Can I get some of those? And you just have to be very forceful. These people just say that that's not appropriate management for this. We don't prescribe opiates for that specific purpose. And then then it just becomes a non-issue, and the patients don't press any further generally. So, but otherwise, like I said, take the time to certainly counsel your patients as well. This is the PMP prescriber report form that's sent periodically by the state of Michigan. It allows you to kind of look at your prescribing habits in relationship to your peers. So, for example, for the period of time that this form was done, my average number of monthly prescribed opioids was for 11 patients, similar practitioners, 7 within my specialty. Number of prescriptions for opioids, 14 versus my peers. So I was a little bit higher than my peers. However, I do have a mixed surgical practice, and we do a lot of surgical procedures that require opiate management for postoperative pain. So that's not anything that's out of the ordinary, if you will. So we're going to get into the clinical practice guidelines for opiate management. This is a little bit of dry material, so I'll try to get through this relatively quickly, but it's pretty important. This was developed by the CDC and a NGO group called the Agency for Healthcare Research and Quality, which this supersedes the 2016 guidelines. This is an update to the guidelines in 2016. They really looked at 4 areas where they grouped their recommendations into, and that was determining whether or not to initiate opiate therapy for pain and really kind of developing some guidelines around what is appropriate for opiate management. Selecting opioids in appropriate dosages, which has to do with the morphine equivalents, or the MMEs, and then deciding duration of initial opioid prescribing, conducting follow-up, and then assessing risks and addressing potential harms of opiate abuse. So essentially kind of covering all the bases to make sure that we are prescribing these things appropriately, but we're also making sure that we mitigate risk as well for those who are at risk for substance abuse problems. So I'll just jump right into these. So recommendation number 1, I'm just going to read right off these. I hate reading slides, but this is a lot of text. That's about the only appropriate way to do it. Non-opioid therapies are at least as effective as opioids for many common types of acute pain. And I think that's something that we all know too, but sometimes it's hard to explain that to patients. Clinicians should maximize use of non-pharmacologic and non-opioid pharmacologic therapies as appropriate for the specific condition and patient, and only consider opiate therapy for acute pain if benefits are anticipated to outweigh risk to the patient. Before prescribing opioids therapy for acute pain, clinicians should discuss with patients the realistic benefits and known risk of opiate therapy. So this is a fancy way of saying that, hey, look, we've got other medication options. We've got topicals. We've got things like Voltaren gel. We've got topical compounds from a compounding pharmacy. We've got NSAIDs. We've got Tylenol. We've got other things that, used in combination, can be just as effective, if not in some cases more effective than some opiate medications. So make sure that we exhaust these other options as well. Recommendation 2, non-opioid therapies are preferred for subacute and chronic pain. So if you don't have acute pain, try to avoid opiate therapy if it's appropriate. Clinicians should maximize use of non-pharmacologic and non-opioid pharmacologic therapies as appropriate for the specific condition and patient, and only consider initiating opioid therapy if expected benefits for pain and function are anticipated to outweigh risks to the patient. Before starting opioid therapy for subacute or chronic pain, Clinicians should discuss with patients the realistic benefits and known risks of opioid therapy, should work with patients to establish treatment goals for pain and function, and should consider how opiate therapy will be discontinued if benefits do not outweigh the risks. And that's a tough one for some people to swallow sometimes, just because, look, if we are not getting where we need to go with opiate therapy and have a game plan to be able to discontinue it, then we probably shouldn't even begin it in the first place. So subacute or chronic pain, like as we kind of discussed earlier, is a completely different ball of wax as opposed to acute somatosensory pain. So oftentimes this requires much more counseling, and your patients have to at least have established expectations, or else it's going to be very difficult for them to get off opiate therapy sometimes. Recommendation 3, when starting opioid therapy for acute, subacute, or chronic pain, clinicians should prescribe immediate release opioids instead of extended release and long acting. So this is pretty straightforward for most of us, those that are controlled substance prescribing, especially in the realm of post-operative care over things like fractures and things like that. We're typically writing for short release opioids, so either for tramadol, Norco, Percocet, some of these other immediate release, as opposed to extended release, which would be things like MS-Contin, oxycodone, Opana, and some of these other stronger medications that we generally don't prescribe to patients, only in rare instances. That's more appropriate for like chronic pain management. Recommendation 4, when opioids are initiated for opioid naive patients with acute, subacute, or chronic pain, clinicians should prescribe the lowest effective dosage. If opioids are continued for subacute or chronic pain, clinicians should use caution when prescribing opioids at any dosage, should carefully evaluate individual benefits and risks, and should avoid increasing dosage above levels likely to yield diminishing returns in benefits relative to risks to patients. So essentially, that's the mantra of start low and go slow. So start at the lowest effective dosage that you think will help patients. And then also step your therapy up. If you have somebody that's taking Norco and it's not helping with their pain, consider either increasing the strength of the hydrocodone in the Norco, so go from 5 to 7.5 milligrams or from 7.5 to 10, as opposed to just jumping up to Percocet, or in some cases, like people will actually just jump up to like the fentanyl patches and things like that, which are more for like malignant cancer pain and things like that, where opiate therapy is indicated. So start low and go slow, and step your therapy up based upon management of patient symptoms. Recommendation 5, for patients already receiving opioid therapy, clinicians should carefully weigh benefits and risks and exercise care when changing opioid dosage. So if you've got somebody that's relatively stable, leave them there, or try to develop a game plan to get them off of it. If they are still struggling with chronic pain, some of that has to do with tolerance as well, which we'll talk about a little bit later in this presentation. If benefit outweighs risk of continued opioid therapy, clinicians should work closely with patients to optimize non-opioid therapies while continuing opioid therapy. So keep your patients on these opiate medications, but then consider other pharmacologic or non-pharmacologic options as well, whether that's the use of something like electrical stimulation or physical therapy modalities. Oftentimes for chronic nerve pain, something like a TENS unit can be very beneficial as an adjunct for management of chronic pain. If benefits do not outweigh risks of continued opioid therapy, clinicians should optimize other therapies and work closely with patients to gradually taper to lower dosages, or, if warranted, based on the individual circumstances of the patient, appropriately taper and discontinue opioids. Unless there is indication of a life-threatening issue, such as warning signs of impending overdose, opioid therapy should not be discontinued abruptly, and clinicians should not rapidly reduce opioid dosages from higher dosages. We'll get into this a little bit later in the presentation as well, with the concept of medication assisted or physician assisted termination of opiate therapy. So abrupt termination obviously is followed by withdrawal symptoms, which are horribly unpleasant. And if patients are trying to get off these medications on their own or trying to abruptly discontinue them on their own, that's a much higher likelihood of abuse and overdose in those instances. And oftentimes it's much better to do a medication-guided tapering off these medications as opposed to just have patients go cold turkey, which is almost certainly unsuccessful in most cases. Number 6, halfway there, when opioids are needed for acute pain, clinicians should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. So this gets into prescribing based on a timeline. So if you're going to prescribe somebody every 6 hours, that's 4 a day, for 30 days, it's 120 pills. And that's also kind of a good way to see if patients are trying to fill their prescriptions early. Are they taking more than one? Do you have concerns about diversion or possible sale or theft of the medication, things like that? Prescribe the quantity that you feel is appropriate, and then you can always kind of adjust based upon patient needs from there. So tolerance being a very real thing, oftentimes patients will require much higher dosages long term to be able to manage their chronic pain. And as we'll talk about a little bit later as well when we talk about the dopamine reward system, I tell patients this all the time. If you come off of these medications, if you come off taking Norco around the clock, your pain will probably go away. Of course, nobody believes me when you tell them that, but it has to do with stimulation of the dopamine centers within the brain. When you move beyond acute pain and get into chronic pain, then the emotional component becomes much more important, and this dopamine reward center is what oftentimes causes the addiction component, and it keeps patients from being able to get off these medications. Recommendation number 7, evaluate benefits and risks with patients within 1 to 4 weeks of starting opioid therapy. So if you got somebody that's on chronic opioid therapy, make sure that you're meeting with them on a frequent basis in order to kind of determine what their needs are, whether it's something that they're going to need for a while. And keep in mind that tolerance builds up pretty rapidly. So oftentimes within like 2 to 3 weeks, patients aren't going to see the same therapeutic benefit that they did like the first couple of days of therapy. And then clinicians should regularly reevaluate benefits and risks of continued opioid therapy with patients as well. So it should be kind of a continual conversation to determine what's best and most appropriate for our patients. Number 8, before starting and periodically during continuation of opioid therapy, clinicians should evaluate risk for opioid-related harms and discuss risks with patients. And clinicians should work with patients to incorporate into the management plan strategies to mitigate risk, including offering of naloxone. Narcan is now much more frequently available. You can typically get like a Narcan kit through a county public health, depending where you're at in the state of Michigan. I know Macomb County does offer those with a brief, like a 1-hour training thing associated with it in its use. And this is something to consider possibly having in like a crash cart in an office as well, so that make sure that you discuss with the patient that based upon what your MAP score is and based upon your risks and other medications that you're taking, you are at a moderate to high risk of overdose with these drugs. And the real story is that the more these medications that they take, or the higher doses that you take, the therapeutic window becomes much smaller, and you can very easily blow right through that therapeutic window and get to a point of respiratory depression with these medications. Even with prescription medications, especially if you're mixing them with other drugs or also with alcohol. When prescribing initial opioid therapy for acute, subacute, or chronic pain, and periodically during the opioid therapy for chronic pain, clinicians should review patients' history of controlled substance prescriptions using the PDMP database to determine if the patient is receiving opioid dosages or combinations that put the patient at high risk for overdose. The big one is benzos. So if a patient is taking Valium, or if they're taking Xanax or something else like that with chronic opiates, those people are going to be at the highest risk for respiratory induced problems. So this is something that I kind of go back and forth on whether or not you should actually share the MAP score and discuss the clinical relevance with your patients as well. But I think it's important for them to know that kind of how we assess risk. And if we look at significant risk factors for overdose, and the patient sees that through our lens of patient care, sometimes it makes a little bit more sense to them. Then when prescribing opioids for subacute or chronic pain, clinicians should consider the benefits and risk of toxicology testing to assess for prescribed medications as well as other prescribed and non-prescribed controlled substances. This is not something that I have historically done, and generally just involves like urine drug screening. Which is important for a couple of different reasons. One is you can tell not only is the patient on opioid therapy, but you can also tell what opioid therapies that they are actually taking. So if a patient pops up positive for opiates, that's fine, but what type of opiates are they taking? Is it for methadone? Is it for hydrocodone? Is it for fentanyl? Things like that. So we're able to delineate and determine if the patient is being truthful with what they're being prescribed. But then also it helps to guide therapies as well and make sure that the patients are not at substantial risk for abuse problems. And so, like I said, it's not something we consistently do, but I could imagine if you're in a practice environment where you're in a hospital, this is something can be done in a pre-op setting. So that's kind of more of an acute setting and not necessarily the most appropriate venue for that. But if you're in any kind of clinical setting where you're able to either do like urine or blood testing for patients, these screenings can be very helpful. And then clinicians should also use particular caution when prescribing opioid pain medication and benzos concurrently and consider whether the benefits outweigh risks of concurrent prescribing of opioids and other CNS depressants. So other CNS depressants would be medications like clonidine, benzos for certain, but there's other medications that can have a sedative effect. Flexeril is a great one. So muscle relaxants tend to have mixed CNS depression characteristics, and cyclobenzaprine tends to be kind of the worst of the worst. It's a fabulous drug, and it's a great medication when used in appropriate instances, but that's another one that can cause CNS depression as well. Tizanidine, not as much. Methocarbamol, not as much, but Flexeril for certain. And of course, benzos like Xanax or Valium. And sometimes antipsychotics too, like Dilantin too, can also play into this as well. Seroquel, medications like that. So make sure that if you have like a polypharmacy patient that's on a number of different medications, their risk of overdose or CNS depression associated with opiate use goes up exponentially. We should offer arranged treatment with evidence-based medications to treat patients with opioid use disorder. Detoxification on its own without medications for opioid use disorder is not recommended for opioid use disorder because of increased risks of resuming drug use, overdose, and overdose death. So this is the last of the recommendations, and essentially what this indicates is that it's very, very difficult for patients to come off these medications and stay off of them. The risk of relapse is much higher if they try to quit cold turkey. Withdrawal symptoms are a horrible, horrible thing for patients to go through. And when they do resume opiates, oftentimes what happens is they're trying to catch up with the withdrawal symptoms, so it's easy for them to overdose and cause respiratory depression and to inadvertently end their own life, unfortunately. So we no longer recommend detox on your own. We recommend for opiate use disorder that this would be a physician-guided process, and that we use some of these long absorption profile medications like Suboxone or Methadone in order to help bridge and transition patient off of opiate medications. All right, so that was a lot of material, and that was a lot of relatively dry material. And I tell patients all the time that the purpose of your fifth toe is to help you find furniture in the dark. So we came up with this brilliant idea to actually come up with the fifth toe hard hat here. So I know some of you at least had a mild chuckle at that. So I apologize for my sense of humor in advance. So we'll switch gears a little bit here. We're going to talk a little bit more about like epidemiology of opiates and opiate abuse problems. And this is a lot more interesting information. There's a lot more graphics associated with this. Thank goodness it's not just me reading off of slides. But as far as the opiate problem, it tends to be relegated more or less to the U.S. as far as its global footprint from epidemiologic standpoint. So we consume about 80% of opiate medications in the world, and a good portion of the world has no access to any kind of opiate therapy. So consider people that have, even like surgical procedures in some places that are undeveloped or underdeveloped, where they're using medications, but they're not using any kind of opiate therapy. I mean, that's we would think of that as cruel and unusual punishment, but really there's just no access to opiate medications in that instance. So 40% of opiate overdose deaths are from prescription opioids. So a lot of the other overdose deaths are from non-prescription, such as heroin or fentanyl, which we'll talk a little bit more. So from prescriptions, we're losing about 46 people a day. So in general, we're losing about 117 to 120 people per day right now in the U.S. due to opiate-related overdoses. And opiate deaths far surpass COVID-19 deaths since 2020. However, the news media would probably have you thinking significantly otherwise. But this is, what the reality is this is kind of an overlooked epidemic, and it doesn't catch as many flashy news headlines, if you will. So in 2016 was kind of an inflection point, and I'll show you this on a couple graphs too. About 64,000 people died from opiate overdose deaths in the U.S. And by 2022, that number had reached 107,000 people. And there was a period of time from April 2020 to April 2021, which is the first 12-month period of time, where they had over 100,000 opiate deaths in the U.S. To put that into perspective a little bit, 64,000 people, that's more people than died, more U.S. citizens than died in the entire Vietnam War from 1965 to 1975. So we're talking about a generational problem here, and I would be hard-pressed to find probably anybody that's viewing this lecture that hasn't been impacted by opiates somehow. I mean, it's impacted my family members. It's of course a number of patients that it's impacted as well, both from an overdose perspective and also from an opiate abuse problem perspective as well. So most of the deaths that we're seeing right now are from synthetic opioids. So that's almost exclusively fentanyl, but methadone is also a synthetic opioid, but its absorption profile is much longer, and it's not an immediate release opioid, so that's not really even considered as part of the conversation here. It is now the #1 cause of death in the age 15 to 50 age group. When you consider that more than double the number of people are dying from opiate overdose than they are from motor vehicle accidents and from firearms related deaths. We'll probably be at a point pretty soon here where we're going to actually double MVAs and firearm deaths together. And of course, one of the problems with opiates too is that pain is only relieved on average about 30% with chronic pain. So the overarching theme to this whole presentation is that if you are taking opiates for acute pain, that is appropriate use. I don't want to scare anybody out of necessarily treating your patients appropriately. And opiates are certainly the standard of care for acute pain. But what I want to implore is that they're not always the standard of care for chronic pain. And if we can get away from opiate use for chronic pain in a lot of instances, a lot of our patient functionality and long-term improvement will go up quite a bit. So, but I tell people too with chronic pain, especially with like nerve pain, spinal cord problems, people that are taking like Percocet around the clock for these kind of things, I tell them like your pain is only about 30% relieved with chronic opiate management, if it's especially any kind of neurogenic source. I'm going to show a couple different graphics too that kind of show how the problem is kind of compounded over the past couple of years. So this is going back to about 2014, 2015, and this is when we really started to see an uptick in synthetic opiate deaths. So this is a statistically significant drug overdose death rate increase. So this is going back almost 10 years now, and this is just from 1 year to the next, and you can see the number of additional states that have increased their statistically significant drug overdose death rate just from 1 year to the next. And keep in mind, this is now 2016, so this is 7 years ago as well. Age-related or age-adjusted rate of drug overdose deaths, West Virginia was a clear outlier at the top. Michigan here is actually sitting somewhere about a third of the way down here. So our 2016 rate versus our 2010 rate, it's gone up for pretty much everybody, with the exception of, I believe, Oregon and Nebraska on this chart. So our age-adjusted rate of drug overdose deaths per 100,000 population is just going up and up and up over that time period, 2010 to 2016. The CDC changed their colors on some of these maps, I think, just to kind of fool people. So drug overdose death rate in 2018 to 2019, we actually saw a slight decrease only in 2 states, in Michigan and in Arkansas. And this is kind of correlates with the increased restriction on prescribing and the use of like the PDMP database and things like that within the state of Michigan. Because I remember a couple years ago there was these big initiatives to really kind of limit, make it tougher for prescribers to actually prescribe these medications, and I think that had kind of a direct benefit. But if you look at from 2019 to 2020, it kind of goes right back up. So we're seeing number and age-adjusted rates of drug overdose deaths continue to increase. And they, like I said, they changed their color scheme here too, and they didn't even involve decrease because it's going up for pretty much every state. The only state that hasn't had a dramatic improvement, believe it or not, is actually Delaware, but I think that's because nobody actually lives in Delaware. So statistically significant change and increase. This is a percent change from 2019 to 2020. We had a 17.2% increase in death rate in the state of Michigan from 2019 to 2020. So this is still an enormous problem. And it's a widespread problem. It's not just relegated to Oakland, Macomb, and Wayne counties. It's everywhere in the state of Michigan. Some of these states were pretty impressive. If you look at states like Florida, Georgia, so the states in the South, Mississippi, 55% increase in death rate, which Mississippi was a clear outlier. Kentucky, so a lot of southern states have dramatically increased death rates, and most of this has to do. So the problem here is that we can see a dramatic jump in time in opiate overdose deaths. And there's a time point that precedes this graph, which is in about 1996. And in 96, there's a company called Purdue Pharma that developed a blockbuster drug called OxyContin. And they had a marketing team that developed an entire marketing campaign in print and news media that was, is your doctor treating your pain? Is your pain adequately being treated? Is your doctor treating your chronic pain? And it became a kind of a marketing phenomenon. So these patients are asking for this medication by name, and this is really predates when we started seeing a lot of significant problems associated with opiate abuse disorder, if you will. So we have kind of a steady state, slow rise in prescription opiate overdose deaths. From the start of this graph in the 90s through about 2012, 2013, and that's where this real inflection point comes in. So the commonly prescribed opioids have kind of a very slow ascent here. And then if we're looking at about 2012, 2013, this is when we started seeing more illicitly manufactured medication. A lot of fentanyl that's coming in from outside the U.S. that's coming from manufacturing centers associated with either organized crime in foreign countries, and a lot of this is coming through, coming across our southern border, coming across our northern border, and coming through the ports. So we're seeing a dramatic increase in supply. And so now we've got a problem where a lot of, especially illicit street drugs such as heroin, for example, are being mixed with fentanyl, and our overdose death rate has gone up dramatically over the past couple of years. And of course, prescribers were partially to blame too for people getting on some of these medications, which we'll discuss a little bit as well. So showed on that previous graphic, it was about 2012, 2013 was kind of that when things really started to ramp up quite a bit. We look at doctors as part of the problem, and part of the issue is that some states have more opioid prescriptions per person. And in some of these states, you see the ones that are all in like this dark purple color here. These states are all essentially states that have more opiate prescriptions than people on an annual basis. So they definitely wanted to try to modify physician behavior and prescribing behavior. And that's actually one of the reasons why I'm actually doing this lecture this morning, is that this is mandated by the state to be part of our continuing medical education enterprise. So we're trying to limit or more appropriately manage chronic pain in other ways than just using opiate prescriptions in order to get better patient outcomes long term. This is the opioid dispensing rate per 100 persons. This is broken down by counties, and this is in 2020, the most recent year that we have access to. So if you look at Michigan, you kind of see the I-75 corridor here. So we've got Oakland County, Genesee County, Saginaw County, Bay County, kind of all right in a row there with our higher opioid dispensing rate. And then if you look at some very specific places, there's like Eastern Kentucky, Western West Virginia, that's kind of a hotbed there. And then some other southern states as well, Alabama, Mississippi, Arkansas as well, where we're seeing an increase in opioid dispensing rate. But it's really a problem that's kind of leveled off over the past couple of years. So we're not seeing as dramatic of an increase anymore. Sources of prescription opioids among non-medical users. So these are people that are using prescription medications that were not prescribed for them. So this is the diversion issue as well. So where are most people getting these medications? Where is this problem starting? And a lot of these patients were given these medications by a friend or relative, sometimes for a very legitimate reason. I sprained my ankle and I've got a ton of pain with it. Hey, you got some of those pain pills left over from your dental procedure, a couple weeks ago. Some of these are being prescribed by greater than one physician. Some are stolen, some are purchased, but the amount that's purchased is actually much less than those who are being given for free. So this is really it gets into the diversion issue. And those that are getting at this graph kind of shows, I apologize, my head is kind of taking up part of it here, but if you look at those that got it free, so the 54% of people that are receiving these medications for free, where did that come from? Well, most of it's coming from just one doctor. So these are coming from your post-op patients where you have a diversion issue, and that's obviously something that we don't have any control over it. But if we limit the supply of the medications, that partially removes part of the issue of demand. However, I like to, being a businessman myself, I like to say that supply and demand is never going to go away, and that these people are going to get medications from elsewhere, whether it's on the street or from another source if they're able to get it. So heroin use, this is going up for all demographic groups, including those with historically low use rates. So the groups that are seeing the highest increase are women, privately insured, and high income earners. This is something that's affecting just about everybody. Estimated use rate is about 0.3 per 100 persons, so about 3 people per 1,000, which doesn't seem like it's very high, but keep in mind that there's other people with opiate abuse problems that aren't making the jump to heroin as well. Some overdose death rates increased quite a bit over the past decade, and the death rate increase just in the 1 year, just in 2015 to 2016, was significantly high, about 19.5%. And if we look at every year, it's going up anywhere 15 to 20% since. So we're still seeing a pretty large death rate from heroin use and from just opiate use in general. A lot of this has to do with mixture of these medications with fentanyl as well. When I was in my first year at Shoal, going back many, many years ago now, there was a big news story about a heroin shipment that was laced with fentanyl, and it killed like 300 people in Chicago over one weekend. And so I remember that from way back in my first year of school. So that was, obviously this is the mixing these medications, and of course if you're purchasing them on an illicit basis, you don't really know what you're getting. So the highest death rate still continues to be for males 25 to 44. Risk factors, most of these people are taking at least one other medication. In most cases it's marijuana, which is still not federally recognized, even though pretty much everybody in Michigan smokes weed now. And 3 out of 4 new heroin users report abusing prescription opiates before starting heroin. So most people that, you don't just say, hey, I'm going to go do heroin today. Most of these people will come from another place. Like they've been taking Norco and it's no longer doing anything to relieve their pain, or they've got this dopamine reward system problem that they're having a hard time kicking. So they make the jump to heroin because it's much higher potency, as we'll show in the MME chart here in a little bit. This is the LD50. This is the amount that you need to kill 50% of us. So as you can see, fentanyl is much, much smaller than heroin. And carfentanil, which is essentially like an elephant tranquilizer, that's not something that's even really in the conversation because it's difficult to make, I suppose. But just to kind of give like a visual representation that the amount of fentanyl that's needed to kill somebody is very, very low. So I always worry about like law enforcement personnel too. Like if you were to accidentally ingest or inhale some of this, that's not a very high amount that you need to cause yourself significant problems. So here's the morphine milligram equivalent chart. 1 milligram of morphine is equivalent to 1 MME. And if you look at like these MAPS reports, these things are based upon your MME amount. So hydrocodone has about the same as morphine, even though they're not necessarily equipotent as far as their pain relief capacity. This is their, addictive potential and risk for problems on an actual quantitative basis. So oxycodone is about 1.5, hydromorphone or Dilaudid has 3, heroin is about 3 to 4, and then fentanyl is exponentially much, much higher. So a very small amount of fentanyl can kill you very, very quickly, and the therapeutic window is very small. So CDC guidelines, 50 MME a day increases your risk for overdose by double, over 20 a day, and then of course at a 90 morphine milligram equivalent per day should be an absolute maximum without very careful justification. So these are for things like malignant pain, cancer pain, or things that people are going to be taking heavy hitter opiates for significant periods of time for, such as like sickle cell crises and things like that. Greater than 50 MME a day, consider prescribing naloxone or Narcan in accordance with appropriate prescribing guidelines. So you can prescribe this and you can give a prescription to a patient for a family member for use. Most heroin overdoses, about 3 out of 4 of them, are witnessed. So people have other people with them that they're either shooting up with or that they're otherwise using drugs in the presence of, or somebody else is in. So how much is 50 or 90 a day? So 50 is a lot if you think about it. So it's 10 Norco 5s. It's not really all that high, to be to be perfectly honest with you. So keep in mind, like, one of the reasons why we're using the Norco formulation now as opposed to Vicodin, which was commonly prescribed for quite a long time, is that Vicodin has 500 milligrams of Tylenol, whereas the Norco has 325. So these people that were taking a lot of pills on a daily basis, the problem wasn't really the hydrocodone problem. The problem was that they were really torching out their liver with the amount of Tylenol that they were taking, and they had reached kind of like a maximum of their 4-gram Tylenol limit on a daily basis. So that was one of the reasons why to go to a smaller amount of Tylenol. So 2 OxyContin 15s, which is an extended release, reaches at 50 morphine milligram equivalents per day. So where you really get into trouble sometimes is if you're using medications in combination with each other. So if you're using like a long-acting opiate medication like OxyContin plus hydrocodone or oxycodone on top of that, so those are the people that get into real problems with their high MME counts and then the risk of overdose. So if they're over 50 morphine milligram equivalents per day, especially for chronic therapy, consider naloxone prescribing, and then make sure that somebody has some sort of training or idea of how to actually administer naloxone. This is carried by all ambulance rigs now in Michigan per state law. And anybody that should be prescribed this, if they have other concurrent problems as well, with a benzo use disorder, history of other substance uses, even alcohol would qualify. So again, we have more opiates in the U.S. And our total opiate consumption per capita dramatically is much higher than anywhere else on the planet. So are we to blame? Or us as prescribers? You can see how the prescription rate and the consumption rate in milligrams per capita has gone up quite a bit over the past, I'd say 2.5 decades or so. So of course, part of the problem is this too. This is a completely subjective measurement of pain, and we even use this for, we consider it to be a validated score when we're doing some of our other, studies and research in orthopedics. What is your pain level? But as we all know, anybody that has spent time training in the past couple of years will say, hey, we've had people come into the ER that are sitting there, they're talking, they're smiling, they're fine, and they'll say they're at 10 out of 10 pain. I'm like, well, buddy, I've seen, exposed bone flapping in the breeze. I'll show you what 10 out of 10 pain is. So the problem is this is just completely subjective. There's no, necessarily correlation with what a patient is actually experiencing and what they're actually telling you. So again, just kind of a summarization of a lot of these things. Opiates are not first-line treatment for chronic pain. Make sure that you assess pain and function and consider non-opiate therapies where appropriate. Evaluate risk of harm or misuse. That's just kind of a summarization of the prescribing guidelines which we discussed earlier. If you're prescribing opiates for chronic pain, try to use immediate release formulations. So use hydrocodone or oxycodone in immediate release formulations like Norco or Percocet. That absolute cap of 90 morphine milligram equivalents per day should be observed and respected. And if they need more than this 50 morphine milligram equivalents, increase their visit frequency. So see these people, make sure that you're documenting everything, and make sure that we're continually assessing, tailoring, and tapering. Some of this for chronic pain is probably more appropriate for those who are doing chronic pain management, but these are patients that we see in our offices all the time as well. So if possible, prescribe less than a 3-day supply, especially for post-op patients. I will tell all of our post-op patients the day of surgery that most people will take this medication for 1 to 2 days after surgery. If you need it beyond that, please call us. And then counsel patients about safe storage and disposal. I'll briefly talk about a study here at the end that talks about how patients did not want to give up their Norco prescriptions after a surgery. So I'm going to run through this stuff a little bit quick here, just in the interest of time. So opiate work directly on receptors in the spinal cord to block transmission of pain signals, and indirectly they cause excess dopamine release in the brain, and at high levels produce feelings of euphoria and intense pleasure. So this is just kind of a brief graphic that shows kind of where opiates works. They work within the spinal cord on these mu and kappa receptors, and they block transmission of pain in the central nervous system. So they are very, very effective at blockade of pain. But this is the other problem we run into is this dopamine reward axis, and this is a little bit of a cumbersome graphic that we have here, but essentially release of dopamine is inhibited by this gamma aminobutyric acid, or this GABA. So I'll show a little bit better graphic here in a second. Side effects of these medications, they do help with pain, but they are mentally impairing. They will delay your recovery, believe it or not. They do increase medical costs. You develop tolerance relatively quickly. They cause problems with gait stability and increased fall risk. So it's very important, especially in anybody who's gait impaired to begin with. Be very selective about use of these medications. Permanent changes to the brain can occur, especially in younger patients. They also double the chance of disability if they're prescribed for greater than 7 days. So opiate use is actually an independent risk factor for the disability declaration, particularly after a surgery. They also increase your risk of post-op infections, believe it or not. And this has to do a lot with the fact that if you're not having pain, you're going to be more likely to be up and on it, or otherwise doing things you're not supposed to be doing. So it does increase your risk for post-op infections. So that dopamine reward center in the brain, this is a little bit better of a graphic. So essentially, things that naturally help to increase your dopamine, such as like food intake, for example. This is shows kind of how this compares with cocaine use, which is causes rapid dopamine release. So essentially, what you're looking at is you have this gamma aminobutyric acid, or GABA, which you have release of this, which is suppressed, which allows for excess dopamine to be released. And this dopamine is really what causes the euphoria, the sensations of pleasure. And if you block this GABA receptor blockade of these dopamine receptors, then you get a much higher activation of the receptors by dopamine within the brain. And this is what causes the cycle of pleasure associated with opiate abuse, but it also causes a lot of the withdrawal symptoms as well if you remove that stimulus. So the problem with, of course, chronic opioid use is that you have a decrease in the normal reward, the normal dopamine reward system. You have a decrease in opioid receptors, endorphins, and motivation, and you have an increase in depression that occurs with it as well. So 1 in 3 year probability of continued opioid use among opioid naive patients by number of days supply in the first opioid prescription. That's a lot to unpack, but what this essentially says is the number of medications, number of days that you were supplied a medication for, and your risk of continuing use at 1 year and 3 years. So you can see it's actually pretty high. So it's almost like a linear relationship. So the more medication that these patients are given for opiate naive patients on their first occurrence, the greater their probability of continuing use after a period of time here. And this is number of prescriptions in the first episodes. This is the same data, it's just the number of prescriptions given. So if patients are getting refills, the probability of continuing use goes way, way up. So if you're getting, if you don't get any refills, that's under 10%. But if you're getting a refill after that initial prescription, then it just dramatically increases. So what about other medications? Why can't I just use tramadol? Well, tramadol is still an opiate medication as well, even though it's not a mu receptor agonist. It still has some problems associated with dependency, and 13.7% of people that are prescribed tramadol are still using it at 1 year. Tramadol does have some other effects too. It can be associated with things like serotonin syndrome and things like that when it's prescribed SSRI medications. So those on chronic opioid therapy have worse quality of life metrics compared to those with chronic pain without opiates. American Academy of Neurology recommends against opiates for back pain, headaches, or fibromyalgia. These are just some kind of random factoids that I decided to throw in here at the end. And then a Cochrane review recommends against use of opiates for osteoarthritis of the hip or knee. I do not use opiates for osteoarthritis for anything, foot or ankle. We use it almost exclusively for fracture care and for postoperative care, and that's really about it. As far as that, if patients need chronic opioid therapy beyond that, I generally will refer them out, which is smart to do from a liability standpoint as well. So efficacy of opiates for chronic pain. This is a systematic review that showed opiates for back pain and their prevalence, efficacy, and association with addiction. They had 4 studies that showed opiates did not show reduced chronic back pain when compared with placebo or non-opioid control. Lifetime substance abuse prevalence ranged from 36 to 56%, so that's a lot. People get on these medications and they can't get off of them. And the prevalence for current substance use disorders is estimated to be as high as 43%. So what are we really doing with these medications for chronic pain? Where we're really kind of prolonging the addiction issues, and people just are not seeing any kind of long-term benefit other than just management of their chronic pain. So what does work? We've got a number of things that are adjunct therapies that can be of some significant benefit. Believe it or not, just counseling, talking to patients about their chronic pain, helping them come up with other tools in their toolbox for pain management as well. From a mental and emotional standpoint. Treatment of mood disorders can be beneficial, and this is where medications like Cymbalta may have some additional benefit, especially with nerve pain. Exercise, physical therapy, use of other medications that are adjuncts as well. Gabapentin and Lyrica are seeing great use with chronic pain. Amitriptyline as well, to some limited extent. This is a randomized controlled trial, the SPACE trial, where they showed randomization of opiates versus non-opiate medications for pain-related function in patients with chronic back pain or hip or knee osteoarthritis pain. So this is for an osteoarthritis study that showed basically patients that were randomized for opiate and non-opiate therapy. The non-opiate group had better functional outcomes, but the opiate group had less anxiety associated with it, probably because they were stoned and forgot that they had back, knee, or hip pain in the first place. We shouldn't be giving this to kids. So teens who received a prescription for opioid pain medication by grade 12, so by the time they're seniors in high school, had a 33% greater risk of misusing an opioid between 19 and 25. And a lot of this has to do with underdevelopment of the central nervous system and brain, which especially in males does not really fully develop until about 24 to 25 years old. So the earlier these patients are exposed to opiate medication, the higher likelihood they are to have dependence and abuse problems associated with it. So over-the-counter versus illicit drugs, percentage of 12th graders who have used these drugs in the past year. So everyone who has younger kids like I do, make sure that they, you talk to your children about the risks not only of illicit drugs but also prescription drugs as well, just because these are, these can be drugs of abuse. And the earlier that you start these medications, the earlier that you take these medications, the greater long-term risks that you have associated with it. 90% of adults with substance abuse disorders started using before the age of 18, and opiate misuse can permanently rewire a developing brain. So that dopamine axis that we talked about, you can cause yourself some permanent problems associated with it. And that's why people who are started earlier on opiates that have addiction problems or that have substance abuse problems tend to be at highest risk for overdose. And it has a lot to do with the underdeveloped brain, and it has a lot to do with impulse control and things like that as well. So as a general guideline, opiate medications should be restricted and should not be prescribed to anyone under the age of 25, other than for very specific instances, such as for like a day or two for post-op. So other options, non-narcotic pharmacologic therapy, nerve blocks, physical therapy. I'm going to run through these last couple real quick here, just so we can finish up. Percentage of people with 50% pain relief following surgery. This actually shows if you mix ibuprofen and acetaminophen or Tylenol together, that it's equally as efficacious as some of the immediate release opiates. This is a randomized controlled trial that showed acute strains, sprains, and fractures that mixing Tylenol and ibuprofen was found to be equivalent to opiates for treating acute pain. This was a foot and ankle study that showed 84 opiate-naive foot and ankle surgery patients. These patients were randomized to receive either 40 or 60 pills after opiate therapy, and all of them received 3-day supply of ibuprofen, DVT prophylaxis, and antiemetic therapy. So the mean number of pills consumed was 22.5, and curiously enough, about a third of the patients refused to voluntarily surrender the remaining pills at their first post-op visit. So, whether it's people they're concerned about having pain down the road, a lot of these people they refuse to voluntarily turn them back over. They want these medications in case they have pain down the road. So there is some sort of attachment to that. And this is kind of an interesting study that really helped identify that. So we do have an appropriate place in the management of acute and chronic non-cancer pain, which we kind of discussed. And like I said, I don't really intend to scare people out of opiate use, but the more that we know and understand about these medications, the more that we can kind of modify or consider our own prescribing habits to limit patient risk. And then it's also just of paramount importance, make sure that you have clear expectations with your patients and make sure you set clear boundaries. Even if that's putting a sign in your waiting room that just basically says we do not prescribe opiate medications unless you have a fracture or post-surgical pain. Sometimes just even things like that can be a big benefit to make sure that your patients aren't trying to squeak these medications out again appropriately. So a lot of information to go through. Of course, thanks to the Michigan Podiatric Medical Association, the Great Lakes Conference. I'll be around. I'll be available following this presentation, and I'll also be at the conference throughout the weekend as well. So by all means, feel free to send me an email with any questions. Feel free to, we have a YouTube channel. It's really my only social media kind of presence. But otherwise, everybody enjoy the conference, and hopefully this was of some at least informative, if not slightly entertaining.